well. Hi everyone, I'm Mo. Thank you so much for joining us today. We've got Dr. Kremer with us today. I appreciate we're starting a wee bit later today, but there is an emergency that Dr. Kremer's been dealing with, but he's still very kindly offered to give us. Hopefully we'll take half an hour of his time and let him get back to work as well. Thank you so much for taking the time to join us. We really do appreciate it. How are you doing? I appreciate it's been a busy day for you.
Thank you. Thank you. So far, all right.
Good, good. So just a reminder before we start, we've got some people joined us in the room here. We've got some people watching us on Facebook. Just be mindful that Facebook's a public forum. You can join us in the room for a bit more privacy. And remember that these Q&As don't take the place of a consultation with your own clinician. We're aiming to provide general medical information and not medical advice. So I'll get on to start on the questions that have been sent in to us. So our first question up today is severe dizziness common in PBC?
Yeah, dizziness is a symptom which is, of course, seen in many diseases, but also in PBC. We have various neurological symptoms in PBC. Dizziness is one of that. And of course, other causes should always be excluded. The neurological phenomena we see are described very different between different patients. I think we should consider that they are real, that they belong to PBC. And indeed, I would always say it is important to exclude other causes of dizziness, of fatigue, of exhaustion, of pain, arthralgia. So in that regard, it depends a little bit on, dizziness is a very vague term of a symptom, I would say. So it depends a little bit of what kind of dizziness it is, whether, this is belonging to this neurological symptom complex we see. But yes, I have patients in PBC. It depends. It can depend on blood pressure. It can depend on other neurological disorders. On many aspects are causing dizziness. So I think those should be excluded. I think this is the important part of this question here. And if we do not find any other cause, then this may be a PBC-associated symptom.
I suppose the thing is not to always assume that that's the connection and make sure that there isn't anything else going on at the same time. Thank you. So we have a patient asking about a DEXA scan. They were told to look at the PBC website by their liver nurse as they follow the guidelines there. So they've done that and they've requested to have a DEXA scan as the guidelines say. However, the NHS are now refusing to do this as a baseline scan. What would be the best way to approach this?
Well, I think it's important to state that in every cholestatic liver disease, the risk for bone loss, for less mineralized bone, osteopenia, osteoporosis is significantly increased. And as stated, the guidelines clearly recommend that. And with that, I would go to my physician I trust, and I would tell this physician how this problem of unwillingness to perform this examination can be overcome. There is no reason not to do that. And depending on the result, another scan may then be between 1 and 5 years, roughly. That is what we recommend and perform in our patients.
That's great, thank you. And if that patient wants a bit of advice about how to approach it with their doctor and the best route to take, if they give us a call, we can help them with that as well. So our next question is around pneumonia. Reaching out to find if we can direct the patient to any information between PBC and pneumonia. I have pneumonia that seems to be inflammatory in nature, and their pulmonologist thinks there is something called organizing pneumonia that is linked to PBC.
Well, I mean, of course, pneumonia is a in particular, the real pneumonia is a bacterial or sometimes also other infectious cause. Otherwise, there are, of course, immune-mediated phenomena which imitate these, infectious-like alterations, also with signs of inflammation. We do not commonly see that immune-mediated, cryptogenic, or organizing pneumonia are linked to PBC. This is not a common association, to be honest, but it should clearly be distinguished which underlying disease or underlying infection may cause this pneumonia. It needs an expert pulmonologist to identify the reason. It may not only be necessary to have a look inside the lungs and flush some fluid into the lungs and reabsorb that. It may even be necessary to take a lung biopsy to have a full understanding on the inflammatory component. And then, if that is the case, in contrast to PBC, real immunosuppressant drugs would be applied to those disorders, but this is not a common link we know from clinical data.
Thank you. We have a patient who's got two parts to their questions. The first part is they've had a thyroid nodule for a few years now, and all the biopsies have been inconclusive. Firstly, could it be related to PBC? And then secondly, they're due to have an operation to remove it. So besides their doctor knowing that they have PBC, is there anything else that needs special consideration when having an operation if you have PBC?
Well, thyroid nodules are commonly seen in patients where we have a lack of iodine, and the thyroid stimulating hormone tries to squeeze out the hormones which are not produced in a sufficient manner. There are, warm and cold nodules. It depends a little bit on, typically we perform sonography, we investigate these nodules, and then we decide whether we need an additional scintigraphy for deciding whether they are active nodules or inactive nodules. And then some nodules may also require a biopsy to have a look under the microscope what kind of cells are in this nodule. Typically, if we talk about PBC, this is an immune-mediated disease. What is associated with PBC is an immune-mediated thyroiditis that is called Hashimoto thyroiditis, and this is an autoimmune mediated disorder of the thyroid gland where the immune cells attack the thyroid glands and destroy the thyroid glands. That does not typically result in nodules, but initially it can be more an hyperactive thyroid gland, and then on the longer term it may become a thyroid gland which does not produce sufficient hormones. That is what we call hypothyroidism, so not enough thyroid hormones. We feel fatigue, we feel exhausted, tired, we may lose hair, have dry skin, and so on. So if you have nodules and the biopsies have been inconclusive, I would go for a second opinion as a first site. You have histology results. I would get at the first site, I would go for a second opinion whether these nodules, which have been biopsies in the past, are of clinical relevance. And resection of the thyroid gland, in my point of view, would only be necessary if you see any dysplasia or, suspect cells, which may hint towards, transformation towards malignant cells. Otherwise, I do not foresee any reason to perform a surgery here if the thyroid function and otherwise the hormone axis are regularly working. So that would be my recommendation in such a situation.
And secondly, just in general terms, is there anything as PBC patients we should be advising our doctors or we should be aware of if we're going in for surgery?
Oh, sorry. Yeah, that's a good point. That very much depends on the disease severity. If you have no cirrhosis, you can mention that you have PBC, but this will not change your perioperative risk for morbidity, complications, and so on. So everything before cirrhosis is of no concern for such a surgery. If you have cirrhosis, then it very much depends on the stage of cirrhosis. So it can be the early compensated cirrhosis or cirrhosis with portal hypertension or decompensated cirrhosis. And actually, from the stage of cirrhosis, there is a mild increased perioperative risk, which is strongly higher in patients with portal hypertension. It depends on the extent of portal hypertension. And the same holds true if there is a decompensated liver cirrhosis. But these are very, very few patients. In those cases, I would certainly be very reluctant to perform any surgery which is not really necessary.
That's great, thank you. Next question is, I was diagnosed with obstetric cholestasis 20 years ago and I had it in both my pregnancies and was given urso. The itchiness never went away and it took a while for my blood test to go back to normal. I've had one liver biopsy which showed mild scarring. I've been monitored since then and I've been on urso as a preventative measure in case I develop PBC, but I've always been AMA negative. Recently my liver tests increased, so they increased my dose of urso. My liver tests improved, so the doctor said he thinks this means that I do have a form of PBC. What are your thoughts on this?
Well, I personally think if AMA is negative, the anti-mitochondrial antibodies are negative, then there is certainly always the question, is this really PBC? We have other autoantibodies aside the antibodies against the mitochondria. We have PBC-specific antinuclear patients, antinuclear antibodies, and they are, not really antinuclear antibodies. They are in the ELISA positive, but if we have an immunofluorescence, if we look what is stained by these antibodies under the microscope, we see a nuclear dot, nuclear rim pattern. These are SP100, GP210 antibodies, and so on. So if those would also be negative, these PBC-specific antinuclear antibodies, then there is only, 5 to whatever, 8, maybe 10% of patients who really do not have any PBC-specific antibody. And I personally always doubt a little bit the diagnosis of PBC, in particular if during pregnancy there was signs of cholestasis, because at this stage during pregnancy we overload our export system in the liver with a lot of female hormones and progesterone metabolites that all need to be secreted by the liver. And in most cases, there are alterations in certain transporters. We have transported for every molecule which goes into bile, and this exists for bile acids, for bilirubin, cholesterol, and so on. And if these transporters are mutated, if they do not function 100%, then we typically see this in pregnancy. Then we term it intrahepatic cholestasis of pregnancy if it's associated with pruritus, with itching. And if this cholestasis persists, my recommendation would be to perform a genetic testing. I would certainly at some stage after such a while also perform a liver biopsy to have a better understanding. How do the intrahepatic bile ducts look like? Is there portal inflammation? Is there portal fibrosis? Are the bile ducts disappearing? If not done, I would also at one stage add an MRCP. This is a magnetic resonance imaging of the bile ducts, so that you can have a better understanding on the three-dimensional structure of the bile ducts. whether they have, stenosis, whether they are otherwise altered, dilated. That would be my recommendation. And of course, some of these genetic transporter diseases also respond to UDCA therapy, in particular the MDR3 variants, so variants in the ABCB4 gene, which are associated with a high gamma GT level. If your gamma GT is low or normal, then other transporter diseases are typically affected. So that would hint a little bit also towards a hereditary cholestasis syndrome. So that would be my recommendation in such a case.
That's great, thank you. We have a question, a general question around asking if there's any new treatments for fatigue and if there's been any research as to why it happens in PBC. This patient has severe fatigue and it does cause them great difficulties.
I think fatigue is very common in PBC, but it's also common in various other diseases. I think it's one of the bothersome symptoms we have hardly understood. We know that inflammation plays a certain role. We have a liver-brain axis which may be involved. We know from some animal experiments that there are alterations in the blood-brain barrier if the bile secretion or bile flow is not optimally working. But there are so far no available treatments. We have to exclude any other cause as physician. We have to exclude, as I said, hyperthyroidism, so not sufficient production of thyroid gland hormones. We have to control for the heart. Is there heart disease which can cause fatigue? Is there anemia? Is there depression? Is there other inflammatory or autoimmune disorders such as autoimmune hepatitis invariant syndrome? So both diseases, PBC and autoimmune hepatitis associated, and so on. And if we have excluded all these factors and still cannot explain fatigue, then I think it's worthwhile to check for clinical trials. There are currently the first clinical trials which have been set up with an NADPH oxidase 1,4 inhibitor, which was positive in a post hoc analysis. I think quite interesting results. So in particular, those patients with moderate to severe fatigue had a benefit there. A larger study is analyzing that, wants to prove that. There are GABA receptors. These are inhibitory receptors on neurons, which are modulated by neurosteroids. And there's also a molecule which influences these inhibitory chloride channels. And so there is more and more interest. We have at least some understanding, some treatment aspects which can be addressed. And if you have severe fatigue, moderate to severe fatigue, it's worthwhile to check that whether maybe a center somewhere nearby offers such a clinical trial.
We have been working with a company on a clinical trial for fatigue and brain fog at the moment. There was some information in the latest bare facts about that as to how you could take part in the trial. We're waiting for some further information to get that sent out, but if anyone's interested in that, please reach out to me and I'll make sure that you get the information when it's available. You can email me direct at mo@pbcfoundation.org.uk, and as I say, there's also information on it on the latest bare facts as well. This next question is a great one, and I don't think it's been asked before. So if one has been diagnosed with PBC and is still unknowingly exposed to the trigger that initiated the disease, along with the genetic variant, will it quicken the rate at which your PBC progresses?
Yeah, an excellent question. The problem is we don't know the trigger. So the problem is we are fully unaware of what is really the cause of the disease. So what alters our immune system to attack the intrahepatic bile ducts. If we would know that, we could maybe even cure the disease, but we unfortunately don't know. We don't know whether certain bacteria, viruses, toxins are manipulating our immune system to suddenly turn its activity towards these intrahepatic bile ducts. We have certainly different rates of progression in our patients. So there are patients with a very slow progression, where even after many years, decades, there is not a advanced fibrosis or a cirrhosis present. And then we have accelerated variants. We call those in particular ductopenic variants, where the bile ducts disappear much faster than in other patients. And that results in a progressive form of PBC, which may advance much quicker towards liver cirrhosis. But whether in these patients there is maybe more of the trigger present or more ongoing trigger exposure is a good point. We can only speculate on that. But yes, it could well be that if the trigger is still present, that the disease may progress quicker. Still, in average, we have to say that the vast majority of patients have rather a slowly progressing disease.
Great, thank you. Got a question around bezafibrate now. Patient that's been on bezafibrate for 6 weeks and have noticed that they're having significantly more bowel movements which have been urgent. This has definitely been a change they've noticed since taking bezafibrate. Firstly, is this normal, and is there anything that can be prescribed to help with it?
I think bezafibrate can cause side effects, adverse events, as in principle every other drug can do. I have seen patients on fibrates who had significant GI problems. And if this is severe, I would rather try to stop fibrates for a moment, see whether the GI symptoms really disappear. If they are still ongoing, I would consider also other causes for these GI symptoms, bowel movements, and so on. There are many, many reasons why that changes, and only the reason that it's occurring at the same time doesn't mean that it's causally relevant, that bezafibrate is really the cause for the altered bowel movement. So I would stop it. If then within a week these symptoms have disappeared, and if you then restart and the symptoms come back, I would say then I would rather look for an alternative to fibrates than treating adverse events with other drugs. If that is really a significant and urgent alteration as described, I would not take fibrates on the long run.
Okay, thank you. Question now about cholesterol and statins, and it's asking, is there any research into cholesterol and statins when you have PBC? The patient's asking to be directed to some written information, which I can do follow in the Q&A, but just anything that could help them at the moment as to whether or not it's safe to take a statin when you have PBC, and if there's any research that you know that's ongoing about that.
Yeah, I personally always say lipids are increased in PBC. In contrast to all other diseases we know, the lipoprotein X is typically in large amounts present in our PBC patients, and purely by measuring the low density lipoprotein fraction, the so-called bad cholesterol, doesn't tell us anything, because this LPX fraction, which is not causing cardiovascular disease, is running in this fraction, and we need to determine so-called apolipoproteins, apolipoprotein B, for example, to really know how much LDL is present. And so I would not be taking statins if there is not an additional cardiovascular risk, let's say diabetes, heart arterial hypertension, familial risk if the mother, the father, the brother, the sister or so have had a myocardial infarction, etc., and smoking or other risks. If it's purely the hypercholesteremia and PBC, this is something we don't treat. We, from a research interest, look into the ApoB content, and the ApoB content is our LDL content in these patients, and that's much lower from the total LDL and the total cholesterol, what we can measure normally in the lipid analyses. And on the other hand, if there are additional risk factors, personally, I don't see any reason to use statins. Statins are well tolerated in most cases. I would be cautious with bezafibrate combination or fenofibrate combination, but otherwise, I think statins are quite safe. Even in cirrhotic patients, I use statins, and statins may cause mild hepatotoxicity in some cases, but in most cases, this is only mild and transient, and only needs to be controlled for if transaminase would continuously rise or remain significantly elevated. Otherwise, that works pretty well.
That's great, thank you. We have a patient who was diagnosed more than 20 years ago with PBC, and they've now had a new diagnosis of another autoimmune condition, PMRGCA. So I had a quick Google, and that is polymyalgia rheumatica and giant cell arteritis. And they're just asking if you have any experience of that or any advice. I also had a bit of a look to see what information was out there, and there is a UK-based support group. I'll send the details of that direct to the patient as well. But I just wanted to ask if you've got any advice around that.
I'm not a rheumatologist, and I think this is clearly a rheumatologist diagnosis. I would really like to refer the patient to this patient group and information then provided by the rheumatologist. I personally know that polymyalgia rheumatica is responding often very well to steroid treatment. Same holds true for this giant cell arteritis, which is a typical combination. So in contrast to PBC, these disorders respond to steroids, and it needs a very, very slow steroid tapering over many, many months. Very slow steps. That's what I learned from the rheumatologist, but I think that is a little bit beyond the scope of my hepatological expertise.
And I will also send out the link of the UK-based support group that I found as well, direct to the patient. Thank you for that. So we have a patient who was diagnosed in May 2023 based on an elevated ALP, which was 202, and a positive AMA. There's some other information in that, doctor, but I'll let you read through it. These tests were ordered by our gastroenterologist who referred me to the Vienna General Hospital. These tests were done again with AMA-M2 coming back negative. This year in May, AMA2 was tested again at both labs and the results were the same as last year. Is there any significance to the fact that AMA-M2 only shows up at one lab but not at the other?
Well, I think that is a very difficult question, which cannot be answered straight ahead because it always depends a little bit on the height of this AMA-M2 value. Certainly, there are different kits used for these autoantibodies. Indeed, some immunological phenomena may occur at some stage where we see antimitochondrial antibodies. For example, if you give a bone marrow transplantation, we see a lot of, this is a very invasive procedure into the immune system, of course, but there we often see autoantibodies coming up and disappearing again. So indeed, yes, antibodies can come and go away, but typically if we have a real PBC, they remain positive. They are not only once positive. So the positivity is a little bit depending on the height of positivity. If it's only just mildly elevated and only once in one lab and all other lab results are negative, I would doubt a little bit the result of this single positivity, and then rather consider additional aspects such as taking liver biopsy, etc., to confirm the diagnosis or to look for other causes, also such as hereditary cholestasis syndromes. And just to, I don't want to be unpolite, but I think maybe
totally
we
understand,
can,
Doctor.
yeah.
Totally understand. Thank you so much for making time for us today. I've got some other information that I'm going to share with the patients, so I'll stay online. But if please, I really do appreciate you being really busy today. So thank you for taking the time to join us, and I hope to see you again
apologize for
soon.
my reduced availability today, but
No
maybe
problem.
next week those remaining questions can be discussed.
Yep, I'll make sure all the questions are added on for the next time. We'll capture all the questions that are there. So thank you again. Take care.
Thank you, Mo. Take care.
Take care. Bye.
All the best. Bye-bye.